Hello, friends. Very good evening. Today is a rainy day. I'm Dr. Shamsul Hoda, speaking from my Ortho World Hajipur Center. I practice at two places, Patna and Hajipur, at different hospitals like Ortho World Patna, Rajeshwar Hospital, Wells Hospital, and other hospitals. I'm presently Secretary Assami India and orthopedic surgeon, complex trauma specialist, and Ilizarov, deformity correction, limb lengthening, bone infection specialist. So today we'll be discussing about the cases of clubfoot and their correction with Ilizarov, starting from pediatric to adult cases. So before I start my lecture, I'll just like to show you the bone frame that we use in typical Ilizarov frame. This is a typical foot frame. We apply two rings here. Foot, this is the foot ring, forefoot ring, this is the hand foot ring. So this is from the side view. We have to take care that we get all the motions. These are the front hinges. These are the front hinges. These are the back hinges. So let's start with our further discussions before we come back to this individual discussion. And before that, I'll show my today's creativity. This is our Ilizarov cycle that my staff has recently made. So I saw this at Ilizarov Center, Kurgan. We have been making more like this. To see you more creativities and give me more ideas. Before that, I'd like to start with our lecture. Let me present my window. We have been seeing that we have different sort of cases coming at our clinics, like you can see the full screen. So in typical clubfoot case of an epileptic case, we start with uh, plaster, then after 1 year we can do for concertis release or even and T lengthening, and 1 to 5 years we usually do with either JES, and after 5 years to more than 50 years we have been correcting lots of simple and grotesque deformities with Ilizarov. So I'd like to thanks to Assami India Academics for making this session where we'll be doing more with you. So why do we need Ilizarov in clubfoot? To place optimal circular extensional fixation in a complex clubfoot deformity resulting in a plantigrade foot, functional foot. So you can see in this video, the patient has bilateral clubfoot. Clubfoots are usually from childhood. Patient has such deformity and they imagine that this cannot be corrected and they have to live a debilitated life. But with the invent of Jess, Ilizarov and different positives techniques and with the guidance of Professor Ilizarov and his mentors that have trained us in different parts of India and internationally. So we can now correct Ilizarov with clubfoot easily. So this is a very regular deformity for us. You can see these results from a bad grotesque deformity in the left foot. This is a doctor from Kolkata. He just got all his children married and then came to me. I operated him. Laser was applied here. You can see the correction is done. And after correction, this complete correction of the foot. Some is more than around 3.5 months only. Now patient can walk freely with the slippers or natural shoes anywhere having a daily activity daily life. So this is the pre-op X-ray. You can see the severe equinus and this is the post-op complete correction. So Ilizarov is a complex deformity. You have to see all the parts. Another example of is a walking man from Patna only. Same deformity correction has been done. You can see while correction, complete correction, walking by without any stick, without anything at the balcony. So that patient can live a very active daily life. It's not a problem. You should get it corrected. So before correcting any major foot deformity, you must be having an idea of the basic planes of the foot, that is frontal, sagittal, and horizontal plane. Which plane has a deformity, one plane or all the planes, and the segments also the forefoot, midfoot, and hindfoot. So we have to define and check which part of the foot has the deformity. In clubfoot, all the segments of the fore, mid, and hindfoot is involved in the deformity. So you should understand the basics before starting any. So Clubfoot, back to basics, is like a gold club-shaped deformity. It's a congenital deformity. Sometimes it's post-traumatic, post-burn. So it is clubfoot is like congenital talipes equinus virus. Starts from birth. That is called congenital. Talipes is talus, and pes is foot. Talus acts as foot. Normally, the calcaneus acts as foot, but here you can see the talus is coming in touch with the ground. So talus is working as a foot, and these are the accessory part. So, and then we have equinus, that is foot in the plantar flexion. It is the deformity of the hind foot. And heel inversion is there at the level of subtalar joint. We'll show you in another picture. So, talus tilts to equinus and varus. So, as we all know from the basics of our MBBS books, the clubfoot has 4 deformities. It's called cave. Cave starts for C starts for cavus, then adduction, varus, and equinus. Cavus and adduction are part of forefoot and midfoot deformity, and it is at the level of mid-tarsal joint. Then varus is at the hind foot, that is at the subtarsal joint. Equinus is the hind foot at the ankle joint. These are the various diagrams for the same. So cavus, you can see that is we have increased arch of the foot. When it is flat, because flat foot, which is increased, we have the cavus deformity. Then we have adduction of the forefoot. This is the adduction. You can see this angular deformity medially. The distal part is going medially, and there is curvature, that is pronation of the forefoot. So we have pronation as well as adduction. These are the second part. We have correct both. Then we have a varus of the heel. Varus not of the foot, but of the heel. This is the hind foot. The heel, the calcaneum has gone into varus. We have to correct it laterally. And then we have equinus. Here you can see there we have equinus of the whole foot. Before this, we have to correct the T lengthening also, plantar fascia release, and if there's the adult patient, we have to do bony corrections also. But in the pediatric, we don't need any bony corrections. So these are the 4 deformity. We need to correct step by step, one by one. The instruments may be different. It may be JS, it may be open surgery, but the principle is same. We follow the Ponsonby's principle of cave correction. So again, just to remind, just for a quick recap, you see here, like in cavus correction, we do a 4-foot increased curvature. It is at the tarsometatarsal joint. This is the tarsometatarsal joint. Here we have the tarsometatarsal joint. So adduction means correction has to be done between the metatarsus and calcaneum. These are the metatarsus and calcaneum. The adduction has to be clear in this area. Then varus, and we have to do distraction across Chopard's and Lick's joint. So distraction is around this joint only. Then for the varus, it is between the tibia and calcaneum. Here, this area. So the distraction across ankle and subtalar joint. We have to do correction of this here and here. And adult, we may need to do some ostomies also. For equinus, it is between the metatarsus and the calcaneum and tibia. So we have to check for the rotation on intermittent malleolus axis also. For equinus, we have to do TL lengthening, we have to do plantar fascia release, and do gradual correction of equinus with the either Ilizarov or some other parts. So this is the cavus, this is the adduction, this is the varus, and this is the equinus. So when we apply Ilizarov, we do it the same way, step by step. We do adduction correction. You can see the frame pre and post correction. It is medially, and we use these hinges. These hinges are being shortened. This hinge can be distracted. So the foot comes laterally. The hind foot remains the same place. The plane is same. So maybe from here to here. So this is the adduction correction. This is the correction of the forefoot ring. Hinges have a very important role to play. So for adduction, these side, middle, lateral hinges play a role. We do compression and distraction from here. Same. We have the plantar view of the same. You can see the correction from medial to lateral. The axis changes. The axis has to change and come to the normal 90-degree plantigrade form. Now for the varus correction, for the heel varus correction, you can see it is between the tibia and calcaneum, distraction across the ankle and the subtalar joint. So you have to, this is the ankle joint, tibio-talar joint, and this is the subtalar joint. We will be using these distractors. We will be distracting these and not compression, there will be differential distraction. We will keep this in place or some sort of compression and more distraction from the medial side. So it comes gradually in place. You can see it comes gradually in place. Then we go for equinus correction. We have hinges anteriorly, we have hinges posteriorly. So this we just compress from anteriorly and distract from distally. And finally, we can do the correction. And the rotation is on intermalleolar axis. Here, the talus work as the fulcrum. The whole movement is around the fulcrum. So this is a very complex deformity. We have to take care of all the deformities one by one. Can do complex correction at once. We have to have the basic knowledge of this complex deformities, right? So this is the example of step-by-step Elizarov application at Kurgan Uti when I went for course of fellowship at Elizarov. This was a pediatric case. You can see it's a beautiful frame has been done. You can see the 3D video of the same. These are the tibia rings, calcaneum wires, 2 or 3 wires as needed. And these are the foot frame, tibia frame. These are the posterior hinges, anterior hinges. And these are the medial hinges to distract. There are toe wires also because we have often have a claw toe. We must never ignore this. So for this, we just apply toe wires. We can correct like this. Complete correction is important. So toe wires are very important not to play. Similar case that built done at MyOT at Ortho World. So you can see this is a grotesque deformity. We did TL lengthening. We did this plantar fascia release. And then we did mid-tarsal osteometry in this case because this is an adult case. So we did minimally open mid-tarsal deformity. This is the tibia rings. And this is a complete foot ring. There was not such claw toe, so you would just use tibia rings, foot ring, and the forefoot ring. These are the distractors. And you can see a complete correction has been attained pre and post operatively. Similarly, we can see in an adolescent girl, we get so many cases of adolescent girls with this, like this, you don't get married, or they think that you'll be debilitated. No, all the deformity corrections can be done. So this is a girl with a magical smile. You can see severe equinus and gradual correction has been done. In this case, no bony correction was done. So you can see this is an ideal frame for clubfoot, 2 proximal tibia rings. This is the first ring, this is the second ring. This is the handfoot ring, this is the forefoot ring. Then you connect with these medial lateral hinges, the distraction on the middle lateral side. These are the 2 distractors we use because to correct the varus and adduction also. So if you do one distractor, if you want to correct the varus and adduction, you have to put distractors. And then finally, there was a claw toe here. So we did with toe wires also. So this is an ideal frame for the forefoot, for the clubfoot. Similar view from the plantar side, similar view from the anteriorly. So if you have any questions, you can ask me on YouTube. You can send me on WhatsApp. At the end, I'll be seeing my QR code to contact with me. So on a sawbone, we just make a stand like this. This is ideal frame. Again, to repeat on a sawbone, and then we'll be talking about this in detail for the details. So let's see what are the basic details of lying a clubfoot frame. We have to do TL lengthening, plantar fascia release, tibia rings, calcaneum half ring, mid-tarsostomy or V-ostomy if needed. If we have a flat top dermis, we can do V-ostomy and foot half ring, hinges and the toe wires. So let's go again step by step. We do a TL lengthening, plantar fascia release. The plantar fascia release is the mini open. Then we apply the tibia rings. So this is the first ring, this is the second ring. We apply the first ring. Normally in a tibia trauma or infection, we apply the tibia ring just 2 fingers proximal. But since we have to apply hinges at the level of ankle joint or talus, so this finger has to be around 3 to 4 fingers away from the ankle joint. This is very important. The first ring has to be away from the ring. We just apply the first ring, that's the distal tibia ring. We apply 2 cross K wires. First, we start from the fibula, go obliquely from posterolateral to anteromedial, and then we can put another from along the shin. Similarly, we apply the second wire, second ring. These wires may not to be, we can just have to connect with 4 rods, and we apply 2 cross K wires, just taking care of the neurovascular bundle. The neurovascular bundle, the vessels go from the most just above the interosseous membrane here. You can easily put wires over here in this area. In this area, are very safe. So avoid this lower parts, the posterior parts. So this is the first ring. This is the second ring. Then this is the clinical application of the same. So we're applying the first ring, then the second ring. You can see there are 2 cross K wires over here. And just to say this, we have in the critical cases we use aluminum ring. This is a light. You can use accordingly. The rods should be around 4 to 5 away from the central area. This is not in the central area, so that we have to take care that they should not impinge with the X-rays. So now it's time of the calcaneum. This is the calcaneum part. We just apply the calcaneum ring. we apply 2 or 3 cross K-wires. We can apply olives so that olives help in correction the hand-foot correction. So we just apply one wire over here, one wire over here. 2 wires already. We can apply 2 cross olive wires, one from here, one from here in this cases. One like this and one like this. And apply the ring, connect the ring with this. And after that, we apply distractors on this case. So then we do the mid-tarsal ostomy. This is a mini open mid-tarsal ostomy over here. We can also do the mid-tarsal before apply the rings. So we can do either way as comfortable you are. We do multiple drills. We do it with the sleeve, with the drill. And then after that, we use osteotome, we just apply two bone levers. This get a small space. We do go with the drill, and the single hole we can do drill in the multiple directions. Go this way, come back, go this way, from the middle and lateral both sides. So you can do like this. So then we have to apply the foot half ring. This is just proximal to the neck. So this is the ideal place of the foot half ring. You can apply 2 cross K-wires, one starting from the first metatarsal obliquely from posterior middle to anterolateral, covering 2 or 3 metatarsal necks. Can emerge from here. And second wire we can go from here, the 5th metatarsal, and taking 3 wires you can emerge from here. You can see these are 2 oblique wires. It has to be oblique, so you get a good correction. Not very near to this, otherwise you will have a clotto. So this is the ideal place, or we can have layer like this. So 2 cross K wires and a half ring. Then the hinges. And before that, we just apply 2 cross K wires over here. So this is the medial for the for the repeating, and this is the middle lateral cross wires. We have to repeat a posterior sandspin also to the calcaneum, but sandspin gives a very bad irritation. So we can apply 2 cut 2 leaves over here in this calcaneum area, that you can just show in some other picture. So they don't give an impingement. I applied 1 medial, 1 lateral wire, and 2 cut 2 leaves, and the posteriorly oblique in oblique directions. So now for the hinges, this is the medial hinge, this is the lateral hinge, these are 2 anterior hinges, and this is the posterior hinge. So this makes like a square. You can correct medially, to distract medially, compress laterally, distract posteriorly, and compress anteriorly, from both the sides. So since there is a adduction and varus, so we have to do more, less of compression on this side, or more compression on this side. So this is like this. So we have to do correction like this. So less of compression from this is this. So this is like this. Okay. So we do more of compression from laterally, less of compression when it comes to neutral position. When it comes to neutral position, then we correct lightly. So like for the repeating, it is like this. So first we distract laterally, compress laterally. Sorry, it comes like this. Then we do compression like this. So this is a gradual compression. We do gradual compression to avoid any neurovascular injury. So this is the role of middle lateral. We just compress laterally first, then take it to a neutral position, then do compression both sides. Simultaneously, we do distraction from the posterior part hinges. So these are anterior distractors. These are posterior distractor. This is the posterior distractor you can see over here. And these are the hinges that works for the rotation of the at the level subtalar joint. These are the universal joints we apply here in these cases. So these are the movements that we see in all these cases: dorsiflexion, abduction, dorsiflexion, abduction. So let's again see the picture of the hinges. My patient, this is the Kurgan patient, this is my patient. These are the 2 anterior distractors for the compression. These are the posterior distractors. We compress from here, we distract from here. And you can see in the picture, this is the lateral distractor. Since this is a medial curvature, so we just do more distraction on the middle side, less on the lateral side. This is the posterior one. These are the plantar and dorsal connectors for the same in the different patients. So the hinges are very, very important. You have to have a combination of male-female hinges so that the movements are very free. The movements over here has to be very, very free. I'll show you in some OT in other case. So how do you apply the hinges? I have some other videos also you can see on my YouTube. So the placement of hinges over here on the other side is very important. Hinges has to be free so that there is no obstruction in the movements. So after this, if you still see there is a Ortho, you can apply 2 hours in all the direction, then bend it to attach in the first ring over here. So we apply all the toe wires like this, connect with the rod and connect with the 4-foot ring. So that they keep, just to maintain the state, we can keep toe wires just 1 month and that is enough. Rest rings we can apply for around 3.5 months. So these are the toe wires. You can see, we just apply, we just bend. This make a rod over here, with a small rod, we can use multiple washers and connect all the wires. It's a very simple procedure. You must not avoid all this. So we usually in India usually miss this. I do in almost most of the cases where I get the Plato. So this is the final assembly of a clubfoot. This is me at the Corconity. Looks like a COVID protection, but this is the usual protocol over there. So this is the toe wires, the distractors. You can see from all direction. You can see it again and again on the YouTube. So this is the final assembly. Just to repeat again, this is the first ring, second ring, cross K wires. Then we apply the hand foot ring. If we want to do ostrom, we can do over here. So hand foot ring, hand foot distractor, hand foot wires from here, and then 4-foot ring and distractors and the toe wires over here to maintain the foot in complete correction. You can see the complete correction is done. In such a bad, this is the initial deformity. So this is the clubfoot girl with a magical smile, pre and post deformity correction. She's still happy. She was smiling through and throughout. So this is a difficult part. All girls don't get a smile. She was crying a little bit here, but so let's have a short demonstration of the saw bone. So how do we apply this in the saw bone? All the rings are there. We cannot demonstrate the toe wires because the saw bone toes are very fragile. So this is the tibia frame. We have 2 tibia rings, distal ring 3 to 4 finger proximal to the ankle joint to accommodate hinges. We follow rule of 2. 2 wires each ring. Can add shank screws with rancho cubes if needed. So let's see how we apply this. The first tibial wire. We are doing posterolateral anterior middle. The association through the rings. You see from here. We are doing posterolateral. You can see from here the proximal wire, 2 cross K wires over here in this area. So we have 2 cross K wires over here. Then here, similar different angles. So the cross K wires are applied. So first the proximal cross K wires, then the distal K wires, then the proximal cross K wires. Then we move ahead. We cut the wires. We bend the wires. We can also apply additional screw if you're not comfortable. I usually don't do, but you can apply shank screw with the rancho cubes. Cut the wire. Bend the wire so that the wire do not impinge with the finger, do not do any injuries. Okay. Then apply the rancho cubes. Okay. Stop. So for the demonstration, apply 2 shank screw in this case. Now this is the calcaneum frame. These are the cross wires. We should use olive if there is a heel deformity also. The cross wire is the half ring. So we can see 2 cross wires are applied here. We should start posteriorly to anteriorly. Okay. Yeah. Now just apply on the fingers. And this is the posterior sinus screw. I was telling about this. Usually they give a lot of impingement and pain. So apply 2 cut olives. So that just a partial part, this part is left, so that to go in the calcaneum, and the olive will go here only. So we'll cut olive, 1 cross olive from here to here, 1 cross olive from here to here. So total of 4 wires. It gives a very good hold. As good as shank screw, and there's no impingement in that. So connecting the calcaneum to the tibial frame with the posterior part. So you can see use the hinges should be free. So these are lateral hinges. If you just repeat it again. Then we have a pause. Let's go back. I'll just show it again. You can see these are the combination of male and females. We have applied a plate so that it doesn't impinge with the movements. So it has to be a complete free movement. The movement is very, very important in different directions. We have to do correction of the virus abduction also. Okay. You can see the hinge. Male female combinations, very, very important. Then you have the metatarsal bars, oblique bars. We have the flow during injury. So this is the other connection. You can take 2 or 3 metatarsals. Normally we take 3 by one part. And then we take another 3 from the different parts. From the lateral part, you can see we have applied the 3 metatarsals on the thigh. We can just obliquely, and the footwear has to be connected like this. Then we just apply you can see here, is the oblique plate. We apply to male-female posts, and then apply this hinges from the medial part. It's the medial part. You see, these are the well connected. So the movement has to be free from all the areas. This is a very, very important connection. See, it's connected from here for one area. You can see it practically in my OT. So the movement has to be free in all the directions. So this is called we connect 3 things to make a universal joint. So the movement has to be very, very free. Free movement is very, very important in all the cases. Next. So these are the anterior hinges. You can see we applied 2 rods. These are the male-female joints that give good movement. There's no obstruction on the movement from here. So one male-female joint and with the plates, you can see sort of to distract us. So this combination is again very, very important. So this is a universal joint. You can see. Sorry. Yeah. So this is a universal joint. So 2 males and 1 female. So you can get a movement in all the directions. So you can get multiple movements. The use of these universal joints are very important. I'm applying the same universal joint in this area, so we can correct the equinus, cavus, adduction all at one go with this. So it's all play of joints and rings. Understanding of a very good understanding is very, very important in all the cases. Pause. So this is I'll just be repeating from here. With a good frame assembly, you can see the virus and adduction and adduction has to be free. It has to be completely free. So you can see this virus abduction has to be completely free. It shouldn't be obstruct. So the joint has to be at place, and then we have the equinus movement are also free. The assembly has to give a free movement. This is of utmost importance in all the cases. So good combination of the hinges, rods and joints at optimal place with optimal wires, with optimal use of shank pins or olive wires, very, very important. Otherwise, you can get another deformity like rocker bottom foot. Correct placement of the ostrom is again very, very important. So this is the final assembly. I'm repeating again and again so that you get a complete, very good understanding of all this. From all the directions, this is the 3D direction. Okay. From both the sides. You can see this video multiple times. So this is the final assembly for demonstration and my workshop from different angles. You should have a very good understanding of the forefoot basic all the anatomy. These are the frame and different parts, different assemblies, different bodies. So the take-home message here again is we have to treating a clubfoot complex deformity. We have to take care of the anatomy, follow Ponceletti's principle, step by cave. You have to correct step by cave deformity to place like caves like cavus, adduction, varus, and equinus to place optimal circular external flexator. Correct hinge placement is very important. Time is something around 3 to 2.5 months. And then we have to put the brace for around 3 to 4 weeks, resulting in a plantigrade function. A plantigrade functional foot is very, very important. There shouldn't be any injury to the tendons or the nerves, so that you will be having a numb foot. So at the end, if you do a good surgery, we get a good, happy Clubfoot family. These are my mentors who have taught me Ilizarov, starting from India to different international, it is like all over the world. This is my QR code. You should take a picture of my QR code so that you can get connected with me on my WhatsApp, my YouTube, my Facebook, my Insta. I'm available when free. My Insta, you can, if I'm not available on calls, you can message me for anything. All the young surgeons, all the patients can contact me, message me. I'll be replying to you always when free. If you have any queries, any cases, of Ilizarov or any complex trauma, deformity, infection, you can connect with me. This is my email ID, drhoda@gmail.com. So I thank you all on behalf of Assami, India, with a happy Ilizarov family. Thank you. Thanks a lot. And after that, I'll just show you again video of this Clubfoot frame before I end. We should learn with this. This is a typical Clubfoot frame that I used to demonstrate in all the workshops, from all the sides. So we start with the distal ring, that is 3 to 4 fingers proximal to the joint. Then another 5 to 6 fingers is the proximal ring. These are the 2 cross cavers for the fibula, from the fibula here to anteromedially. Another cross cavers. These are the neurovascular areas. We have to save this. Another 2 cross cavers. You can apply to Shamsul for support if you're not very safe, feel safe. Then before that, you have to do a tibia release and plantar fascia release. And you can do a mid-tarsal ostomy from this area. This is the area from you can do a mid-tarsal ostomy. Okay. And you can see there are 2 cross cavers for the calcaneum. 2 cross cavers are here. You can use olives if you have to correct the heel virus also. Heel adhesion also, sorry. This is the Shamsul. I use 2 cross olivars from here. So this gives a little irritation. I hardly use any Shamsul in my Ilizarov cases in lower limb, unless there is a hip or the shoulder upper part. So VARS gives a very flexible movement. So then we apply the forefoot. These are the cross cavers, same jawbone. 2 VARS here, 3 VARS here. This is the foot ring. And you can see we have applied universal hinges. One male is here, another one male. Then there is a distractor. The same wire, when you have applied this wire, we have connected the same with sort of male part. Then again a male, we have applied the distractor on the lateral part. Similarly, if you come here, you can see this is a male. This is a male part. Another male, 1 distractor, 2 distractor. So 1 joint, 2 distractors. We have to distract the medials. We have to distract here. We have to distract here. We have this. Okay. We have to distract here. We have to distract here. Distract here. So these are the different hinges: 1, 2, 3, and 4, and 5. So main is from we have to distract from the medial side, more, less distract from the lateral side. We have to compression more from the lateral side, less from the medial side. In the coming normal neutral phase, we can do more compression. Simultaneously, we have to do distraction from here in our post-op, starting from 7 days. If we have done a osteotomy, then have to wait 7 days. Otherwise, we can do all the rest of correction from next day only. So within around 15-20 days or maximum of 1 month for a grotesque deformity, this is the single ring that works for all the cases. All the cases you can see from here. This is a clear picture. If you have any queries, you can ask me. And you can keep this ring after correction, keep this ring for another 2 and 2.5 months. And then we remove this, apply a slab for 2 to 3 weeks or maybe 4 weeks. Then we apply a brace. When we apply a slab, we just ask our shoe person to get the measurements for the brace. And then we ask the patient to wear the brace for another 2 months or 3 months. Then we just promote them to wear sports shoes. So thank you all. So let's ride on this Ilizarov bicycle. You should have a good knowledge of the mechanics, so you can make anything in this world with this. Thank you. Thanks a lot. If you have any query, you can drive with me in the bicycle. And thank you on behalf of Ortho World and Assam India. Namaskar. Assalamu alaikum. Sat Sri Akal. Allah Hafiz. Good night.